Again, I think that we're moving into really a great era in the treatment of urothelial carcinoma. One clinical trial that's matured is the Instillagin trial, which is a phase 3 trial that looked in those patients who had received at least 2 prior courses of BCG. Instillagin, which is basically an adenovirus interferon agent that's administered intravesically. These patients were evaluated, and at 12 months, that was the primary endpoint for recurrence-free survival. This was the first approved adenovirus vector-based gene therapy for high-risk BCG unresponsive non-muscle invasive bladder cancer, and that was in December of 2022. As we see here, overall, it was a 45% complete response rate with carcinoma in situ at 12 months, with or without TA or T1 disease. And of course, over time, we do lose some of our patients, but this is actually what we would consider to be the benchmark now for those patients with BCG-refractory disease. So there are variations on all these themes now in terms of our clinical trials. We're looking at BCG-naive patients in this particular slide. This was published by Neil Shore in Surgical Oncology a couple of years ago. We see that checkpoint therapy is now moving up front. Pembrolizumab is FDA approved in those patients who are either ineligible to receive a cystectomy or refusing a cystectomy and are BCG refractory. And now pembrolizumab is moving up front in combination with BCG. Other checkpoints are also being looked at in combination with BCG. Targeted therapies are being looked at in combination with epirubicin. There's an encapsulated rapamycin that's also being looked at compared to placebo. Angiogenesis agents are also being looked at in this particular state. So we have a variety of different drugs that are being looked at in this area. BCG recurrent, again, checkpoint therapy, treatment with pembrolizumab and BCG, intravesical BCG with other checkpoints is also being evaluated. Pangatinib is being looked at in terms of a targeted therapy. So the other areas in BCG refractory carcinoma or unresponsive, other checkpoints such as durvalumab, atezolizumab was evaluated in the Southwest Oncology Group. Again, the benchmark has got to be a response rate at 12 months overall. So one of the studies I think that's very, very important that's going on right now, it's an NCT trial comparing intravesical BCG to gemdocetaxel. As we know, gemdocetaxel is an active agent in BCG refractory patients. And because BCG has issues in terms of shortage, this is, I think, an important trial that will potentially either look to be equivalent to BCG or hopefully superior. But again, the shortages have caused problems with BCG, and there have been adjustments in dose to try to compensate for that. One of the interesting trials that's going on in the cooperative group is thinking about BCG immunity. If you remember the early studies with BCG was given intradermally as well as being given intravesically. And this was, again, to enhance immune response. So the PPD test may actually help us determine a clinical outcome with these patients. And those patients who are PPD positive in this particular study did better than those who were PPD negative, implying that an intact immune system would lead to better results. So in the Southwest Oncology Group, SWOG 1602, which is known as PRIME, it's a randomized trial to evaluate the influence of BCG strain differences in T-cell priming for BCG-naive high-grade non-muscle invasive bladder cancer. These patients have to be BCG-naive and PPD negative, and they're randomized to receive 3 different versions of BCG, either intravesical TICE at 50 or 80, and then intradermal BCG along with the intravesical BCG to see if there's actually a better outcome. I think one of the other more interesting areas of non-muscle invasive bladder cancer involves what's called a pretzel, which is this little device seen on the right. It's a little bit bigger than a euro. Of course, if inflation, that actually may turn out to be a little bit smaller. But this device can actually elute drug into the bladder, and it's inserted cystoscopically. And you can put a variety of different agents in this particular device. I mean, this is certainly a better way to deliver drug. This particular example is using gemcitabine. But some data that was presented at the ESMO meeting I thought was very, very fascinating. As we know, there's a higher rate of FGFR alterations in those patients who have non-muscle invasive bladder cancer. Erdafitinib, which is a drug that's FDA approved for those patients who have FGFR3 or 2 mutations in metastatic urothelial carcinoma, that drug is actually, I think, a difficult drug to administer systemically. It causes severe fatigue, hyperphosphatemia, nail bed changes, and in general, I think in some patients, it's a very, very poorly tolerated drug. So if you're going to be administering an FGFR3 agent to a patient with non-muscle invasive bladder cancer, you want to limit the systemic effects, and certainly this is one way this may be overcome. So TAR-210, this pretzel has been primed with erdafitinib, and this trial has looked at those patients who have FGFR3 positivity and high-risk non-muscle invasive bladder cancer, and also in recurrent Ta/T1 disease that has visible target lesions. There's been a dose escalation study, and as we see, the 82% of patients that were presented at the ESMO meeting this past year were recurrence-free. The recurrence-free, this was overall at 9 months. The median has not yet been met. 87% achieved a complete response in cohort 3. And moving on to metastatic urothelial carcinoma, there are some clinical trials which I think are very, very important. As I mentioned in the previous talk, one of the problems with enfortumab is peripheral neuropathy. Another problem with enfortumab is rash. That can actually progress to Stevens-Johnson syndrome in some patients. So we're looking for other ways of delivering nectin-targeted agents to the cancer cell. So a bicycle compound is a short linear peptide that's attached to a scaffold, and this bicycle can actually bind to different protein types. It has high affinity and high selectivity. The advantage of this is that it's smaller molecular weight than an ADC, it's precise, it's renally cleared, and it has the potential for reduced immunogenicity. So these bicycle compounds have actually been linked to MMAE, and this particular conjugate has actually a high rate of clearance, it's highly selective, and it also has a high penetrance due to its small molecular weight. And so the DEVALO-1 trial looked at patients with a variety of different solid tumors, and urothelial carcinoma is one cohort. It's also important to remember that nectin is expressed in multiple tumors, including ovarian and non-small cell lung cancer. The dose escalation trial demonstrated a complete response rate. This is early, and these are refractory patients of 4%, 35% partial response rate, but perhaps less neurotoxicity and perhaps less skin toxicity. So this compound is being combined with pembrolizumab and is in a phase 3 trial right now compared to standard of care chemotherapy, either cisplatin with gemcitabine or carboplatin with gemcitabine in metastatic urothelial carcinoma. Emerging therapies of interest in urothelial carcinoma as well include HER2-targeted agents. Dasatinib vedotin is actually a drug that's approved in multiple tumor types and can be used in urothelial carcinoma for those patients who are expressing HER2. Trastuzumab deruxtecan is also an ADC that's a topo-1 targeted agent. There are a variety of other nectin-targeted agents that are out there. The TROP2 agents, we know that sacituzumab had some recent negative data in terms of toxicity, but that also is being evaluated by other monoclonal antibodies. The question is whether sacituzumab is going to be withdrawn by the FDA. F2A is also being looked at in terms of a bicycle type of compound. And there are also some ADC doublets that are out there. In other words, an ADC delivering 2 different drugs at the same time, that's potentially one way of overcoming resistance. So in the interest of time, I'm just going to skip over these particular slides and move on to the fact, at least the final one, is the linker technology is important to ADCs. And half-lives may be important to this particular issue. And the fact is that free MMAE or other agents may actually also come into play. There's another Nectin-targeted antibody that is looking at this particular issue that may actually have less toxicity because less free MMAE is liberated. So my 10 minutes are up, and in conclusion, multiple trials are focusing on novel immune therapies and targeted therapies for BCG-refractory recurrent urothelial cancer. Agents targeting Nectin, HER2/neu, TROP2 are being investigated in metastatic disease, both in the upfront and refractory setting.